A
Right.
very good morning to everyone who's listening to Friday at Divyanj. Uh, Today we are more than enthralled and super excited because things which we have learned in our theoretical books or we have just seen in our textbooks, a couple of lines or couple of pages maybe maximum. But we always understood that it is very important because we would always get questions in our question papers, but we really didn't know much about it beyond some few lines. That is Bobath approach. We all students and all professionals of this field are very much aware of Bobath approach in terms of its name and few things here and there. But today I'm so honored that somebody has come as an representative of Bobath Center from UK to actually tell you about what is Bobath, where you can use it, what is the efficacy, and an overview about it. A very warm Yoni to this interview from India. A very warm welcome to you.
Thank you
Let
very
me
much.
let me introduce you to our audience. Uh, Yoli Broik has been working in National Bobath Center in UK since around 3 decades. She is working as speech language therapist and she's a clinical head there. And today she is going to share all about what she has learned in her massive and plethora of experiences in the Bobath Center, and which is she's so attached to, and she's a lovely person and a lovely speaker too. I'm so enthralled to have you today here on this dais, Yoli.
Thank you,
Uh,
Apita. Thank you for your warm, kind words and for the invitation.
it's our pleasure. Uh, that brings us to the first question, Yoli. Uh,
Mhm.
we have read about cerebral palsy for sure, but I would also like to understand what cerebral palsy is to you. What is your understanding? Kindly share with us.
Yes. For that, I'd like to share my screen with you because I've put that in a little slide because I think that's always a very useful way of getting commonality in how we see cerebral palsy. So
Yeah.
the internationally accepted definition of cerebral palsy, I hope you can see my screen, Apita.
Yes, I can see. Can you please
Yeah,
put it in slide view?
wonderful. Lovely. Is that it is a group of permanent disorders of the development of movement and posture causing activity limitation, which are attributed to non-progressive disturbances that occurred in the developing fetal or infant brain. And these motor disturbances are often accompanied by disturbances of sensation, perception, cognition, communication, and behavior, by epilepsy, and by secondary musculoskeletal problems. And if we ask ourselves, what does that actually mean to our clinical practice? It means that this is an umbrella term that describes a multitude of conditions. And in my 30 years of practicing, I have not met two people who present in the same way. The damage to the developing brain is irreversible. The damage is there and cannot be recovered. But the effect of brain damage in all these people who have cerebral palsy is the disturbance of posture and movement, which most importantly affects their activity and their participation in society. It is non-progressive, but it changes sometimes very dramatically in presentation over a lifetime. And that's a very, very important thing for us as clinicians to understand. And it is often accompanied by a range of other conditions. And I just want to take you to some very specific statistics that
Please.
might inform particularly speech therapists. For instance, the impact of feeding difficulties on people with cerebral palsy, and that a diagnosis of malnutrition was 3 times the ratio of non-CP hospital admissions in a cohort of people between the ages of 2 and 17 in the United States over a 13-year period of time. And the estimated clinical prevalence, for instance, is between 30 to 40%. And a lot of these people will have additional issues such as epilepsy, lung disease, gastrointestinal problems, musculoskeletal deformities, etc. So why is that so important? it is incredibly important because this affects quality of life. So when we work with our families, people with cerebral palsy, the most important thing that we should do, and that we do as Bobath therapists, is saying what matters to you, not what is the matter with you. It is what matters to you. And that highlights that the Bobath concept comes from a social model of disability rather than a medical model of disability. And it's geared towards empowering people to address those things in their life that they find most significant, that matters to them most.
Right. Nice explained. Okay. So, because it is a neurodevelopmental disorder and we understand that Bobath is very structured, can you kindly guide us? What is the rationale? Or how is it different? What is Bobath approach? Can you please highlight on that?
Yes. So I wouldn't actually necessarily use the word structured. I think there is an old idea of what Bobath is, on the basis of long history of the Bobath concept developing, but it's actually a very modern concept now. And the modern element of this concept is that it provides a framework for clinical reasoning. So the structure that you mention comes back if we look at how do we actually assess the things that influence the way someone is doing something on a daily basis, something that matters to them, something that allows them and enables them to be the person they want to be in society. And that is the structure. So for that, we go into the ICF framework. And I do want to share this with you because maybe not everybody's using that on a daily scale. What I'm going to do is I'm going to share my screen again with you and just take you to the next slide, which is this one here. Can you see this?
Yes, I can.
Yeah, so this is the framework, the ICF framework that we are all probably familiar with, which is designed by the World Health Organization and is there to classify functioning, disability, and health in a particular health condition, in this case, cerebral palsy. And if we look at how the Bobath approach uses the ICF model, we can see where our clinical reasoning comes in. And instead of starting with this person has an impairment, we start with this person would like to be able to do. And in order, so that takes you to the top left-hand side, participation in the screen. And in order to do this, they need to be able to do X, Y, and Z. And this requires their body to be able to do A, B, and C. So if I give you an example that would relate to SLTs, I would like my child to be able to eat using a spoon, taking food off a spoon. Because I would like to be able for other people to feed my child, for instance, or to be able to go out, go to a restaurant and use equipment there. This activity needs my child to be able to hold their head in such a way that they can bring their lips together to come over the spoon at the right time to clear the spoon with their top lip. If we look at body structure and function, that means that my child needs sufficient head control and lower jaw control to selectively move their lips and take the food onto their tongue, and then from there to process the food onwards in a safe way. If we then look on the top right corner of the screen, we then go into an analysis, and this is really important, of understanding typical development really well. What would I normally expect for a child to be able to do this task, to be able to eat that way? Would I be able to expect that at the time that this child is in their life? So does that make sense? You know, it makes absolutely no sense to ask a child to eat a raw carrot by the time they're 1, because they don't have the jaw structure and the dental structure to be able to do that. So what can my child do and how do they do it? We start with what are the elements that are already there that are useful to my child? because we want to use those to start our therapeutic intervention. We start from what they can already do, and then we say, what are they less able to do and why? And then we say, okay, what is making it difficult for them to do that? What are the impairments that are getting in the way? And very importantly, what might be the effect of the way they do it right now over a lifetime? What is detrimental about that? So if you think about eating and drinking, for instance, if you can only receive food with your head tipped back, your mouth wide open, and someone is pouring it in, the risk of that going down your airway is massively increased. Now, that might lead to the odd chest infection in childhood, but in adulthood, that would actually lead to significantly reduced lung function. And that's a long-term effect that we need to be aware of, because we know that 89% of people with cerebral palsy get to the age of 35 at least. So a large amount of people go into adulthood. So we need to be aware of those things. We then say, okay, what is the collaborative plan of intervention? So we work with the family at the center of care and say, okay, what can we do together to improve this activity and this participation? We're going to formulate ideas about what would be the impact of if that child moved differently, if we help that child to establish other ways of being able to get their mouth together. And then we're going to set goals together to evaluate outcome. So that might be a SMART goal or a GAS goal, where we're very specific about what it is that we're trying to achieve. So for instance, Johnny can, at the end of this week, 1 week treatment, Johnny can take food off a spoon using his lips to clear the bowl 5 out of 5 times with handling. And then the following week, that might be Johnny can clear the bowl of the spoon using his lips, tucking his chin in, following verbal prompt 5 out of 5 times. Johnny can, the goal from that would be Johnny can clear the bowl of the spoon 5 out of 5 times without verbal prompting, but by looking at something on his tray. And that is kind of how you build your therapy. It's always forward-looking, and it is very much about doing daily activities. It's not about exercises. It's not about do this 10 times and then it will get better. That is the outcome measure that we use, but it's very much about helping people understand what is the common factor that affects all of the things that they're trying to do with our child. And we take into account the personal context of the client because they center to their care. Environmental context, things that help them, and things that might become barriers in them being able to achieve it. And that would then lead to the outcome. Have you been able to achieve this or not? And that leads us then very nicely to how do we measure that? Because it's very difficult to measure your impact. The only impact really that really matters is what the family tells you, what you have achieved in their eyes, in their living that in their lives every day. Does that make sense?
Absolutely, absolutely. From being clinician-centered, things have changed, and we are more into patient-centered approaches. How they are feeling, what is their outcome from their point of view.
Yeah.
We echo that in India as well. And now that takes me to another curiosity: is you are seeing so many children with cerebral palsy day to day. Apart from oromotor skills, is there anything else also? You already talked about your expansive framework, I'm understanding. From an SLP point of view, would you also like to add anything very important which needs to be seen in a child?
Yes.
Please
So,
do share.
yes, I mean, I think there are some very important things that SLTs particularly should be aware of. And if it's okay with you, I'd like to share my screen again because I've got a beautiful
Please do. Please do.
piece on that. I'm just going to show you. Let me just take you through that. So that little statistic I showed you about malnutrition, for instance. Hold on, let me just try and see if I can take you back here. Why does it matter So why do SLTs need to understand cerebral palsy as a lifetime condition, but not just that, but understanding trauma? And trauma is not just a trauma in the brain of the child, but it's also trauma that has happened to the system around the child. That can be the parents, it can be the siblings, it can be the wider family, grandparents. And I want to explain a little bit about that. So when a child sustains brain damage that causes cerebral palsy, the brain of the child has a high level of neuroplasticity, which means that there's a lot of adaptation to do things differently, to find other ways of doing things. We know from research from neuroscience that the brain will start to grow pathways that are used a lot, and it will prune the pathways that are not used very much at all. Now, that can be a good thing. The child is finding other ways to do it. But if the way the child is doing it increases their tone, for instance, they get very stiff or they become very asymmetrical, for instance, then that can be a detrimental thing. And we as SLTs need to be aware that that pathway that produces an atypical response that is being grown and grown and grown can over a lifetime cause enormous problems to people with CP. So think, for instance, about if you would use a switch to use a communication aid, and every time you use the switch with your left hand, your body veers to the right because you've got difficulty coming across midline. Then over time, the correction back to the middle doesn't happen anymore because people, need that switch to talk all day long. So that could cause a scoliosis over a lifetime. And that then by itself might mean that that person in time may not be able to use that switch anymore because they're getting stuck, because they're in pain, because they're deformed. So from an SLT point of view, our ability to see very young people and understand how our intervention is going to impact them when they may be in their 60s, that is enormously important. It also means that we should understand that the trauma that parents and the wider system has may cause them to interact with their child in a way that may not be helpful. And a good example for that is, for instance, that when a child can't communicate very easily, that parents will start to do things for the child. And that changes the interaction between parent and child. That changes the buildup of in that child's mind of who they are, what they can do, their self-esteem, their self-image, their self-worth, and that affects them mentally. But it also means that the parent may feel that they can never give their child independence because they worry that the child cannot assert themselves and that harm may come to them. So the parent's life is changing too. And that process of having to let go of what they thought was going to happen when they had a child to what actually is going to happen when they have a child will affect the mental health of the people caring for children with CP too. And we need to be aware of that. So working on communication, working on breathing, voice, working on independent ADL skills, working on speech if we can, saliva control, all of those things, SLT should be understanding the impact of what they do over a lifetime. And that is very Bobath. That ability to analyze that. What is typical development? What is helping the child? What is missing? What can they do with a little bit of help? And what is not helping them? That analysis, that is very, very Bobath.
Right. Beautifully put. Now I got the point that apart from doing an assessment, we get very professional at times. We have to be doing more of in-depth understanding of the functional implication that child has and
yes,
include that in the therapy program as well to see the efficacy. I
very
understand.
important. So and it is exactly the what I spoke to you about earlier. If I take you through what it might mean, it is the fact that I don't know if you can see my screen at the moment, but
I can see
your service delivery should be about what your service user needs. So we don't use the word patients here because people are not ill and they should not be in a medical model. The services that we deliver are there to address the elements of function in their life that they go through every day. So we call them service users, and that puts us on a more even keel. So we are trauma informed and family centered, which means that the needs of the family come first and the service delivery moves around that. And we would always strive for optimal participation, so ICF led. But we also have to take into account practice guidelines on good practice. So here in England, we have something called the NICE guidelines, and they're the National Institute for Clinical Excellence that tell us what is and what is not appropriate behavior with people with cerebral palsy. And we use very up-to-date evidence from research and neuroscience. So we adhere as much as we can to emphasize a social model of disability rather than a medical model. This enables and empowers people, and that is what they need, because really society is there for all of us. And just because you have cerebral palsy, that does not make sense. It doesn't make any difference to the right you have to access society like everybody else. But the Bobath clinical reasoning gives an in-depth analysis of posture and movement. And we set collaborative goals and activity programs, constantly asking, how is this person going to do it? Why should they be doing it that way? We try things out. We evaluate non-stop. So there's evaluation in the course of our sessions all the time. And this is all with view of the future. And then, of course, we use classification systems such as the GMFCS, the MAX, the CFCS, and EDAX, which are all there to enable people to have a similar understanding of where people are in their skill sets. However, these are not diagnostic tools, they're classification systems.
Great.
Yeah.
Yes. Okay. So I can understand the assessment, the way you do the assessment. You gave a very good guideline to go through it. Now, can you also tell us how do you set your goals before
Yes.
giving therapy? Please do.
Of course. So our goal setting is always done in collaboration with the service user. So either the person themselves or their family. And that can sometimes be a little bit tricky. And what I mean by that is we as therapists tend to use jargon a lot. We're comfortable with jargon. We're comfortable with terminology because it makes us feel that we're in control of what we know. And when we talk to other professionals, they understand the same thing. But when you talk to families, right? But when you talk to families, they talk about, I want my child to be able to drink a cup of water without choking. I'd like them to be able to do that. They, whereas speech therapists would say, oh, I'd like them to be able to take this much water in a day to prevent constipation and to not lose more than this much and to be able to do this and to be able to do that. But parents just say, I'd just like my child to have a drink. That's all really. So we use language that is easily understandable for anyone coming in contact with that child. And then what we try and do, hold on, let me just go back to sharing that with you. Oops. Sorry, let me just share my screen and take you to goal setting. So for instance, we then very readily use these kind of goals. So specific SMART goals, goals that are specific, that are measurable, that are achievable in the time frame of your intervention, that are realistic, and that are timed. So for a 1-year-old who has full body involvement, maybe level, who potentially could be level 4 or 5 GMFCS, so the more severe end of the spectrum, it would not be realistic for a child at the age of 1 to eat a raw carrot, because in typical development, we know that's not realistic, but also looking at the way that child presents, that goal is probably not achievable. Certainly not in a short period of time. Goals tend to be short term, aims are long-term. So you together work with the family to say, okay, what in the long run would really make a difference to you? Well, I would like to be able to take my child to a restaurant and for them to be able to eat something on the menu there that I can easily adapt for them to eat, and to not have to worry that they are going to choke while we're there. And so you said, you break it down and you say, okay, where shall we start? Well, we start with, why is currently that a thing difficult to do? What can the child already do though? They can sit, but when they're sitting, we see that they're not holding their trunk very well and they're falling to one side and then they tip their head back, and that is where they're being fed. Then we measure, if we set a goal that's measurable, we say, okay, by the end of this week, your child can sit in such a way that they are able to tuck their chin in and bring their lips together. And we're going to achieve that by helping them with their head control, handling them. And then we are going to measure it at the end of the week by the child being able to do it 5 out of 5 times while being handled, or 3 out of 5 times. And we are hoping to achieve that at the end of this week. That would be then a SMART goal that we evaluate at the end of the intervention. But we also ask the family, for instance, families of a young child, to fill in something like the Caratane parent confidence scale, or we do the Canadian occupational performance measure. And we do that at the beginning of intervention, and we do it again at the end of intervention to see, has it actually made a difference in your daily life with your child? Has this, what we've done, actually made a difference to you? How confident did you feel at the beginning? How confident do you feel now? Because it's all good and well us being able to do things, but the reality is that people in their lives need to be able to go home and do things themselves. So we do a lot of work on handling with parents. So parents are handling and we are supporting them. We're bringing in equipment, we're bringing in technology, and we start very, very early with that, because it's not about this utopia of, well, you know, it'd be lovely if they could sit without support. But if you can sit without support, but you can't use your hands, what point is there in doing that, right? You have to ask yourself, have I got justification to be working on this if the child then can't feed themselves or can't play or can't talk? The answer is there is no justification for that, so we don't do that. And that is a very important thing to understand about the Bobath concept as it is now. We don't do things for the sake of doing them. We only do them in relation to function and participation. Other than that, we do not find justification for doing the things we do. It's as simple as that. It's trauma-informed, family-centered, holistic. We don't just look at our own little individual area. We look at what else is going on in that person's life. You know, what else can they do? What else do they need to do every day? It's got to fit in. And that makes it possible for people to say, okay, yeah, I can see that works and I could do that because I'm feeding them anyway. I'm playing with them anyway. I'm putting them in the car seat anyway. So yeah, I can do that. That will work for me, rather than a set of exercises, which is what we don't do.
Totally. Makes sense.
Sure.
I'm just one more curious with the same point. What diagnostic, do you believe in diagnostic labeling? Do you believe in diagnostic labeling, or what do you use as a professional diagnosis at the end of your assessment?
Yeah. Right. So I don't diagnose anyone. That is not my role, right?
Okay.
And many people come to us with children who don't have a diagnosis yet, because we don't just see children with cerebral palsy, because it is anyone who's got a problem with posture and movement that results from a neurological incident. So where there is a neurological disability there. So I see children with Down syndrome. I may see children with genetic disorders. I see children with very specific conditions, but they all have in common that their posture and movement are affected. So I don't do diagnosis, but I am able, on the basis of my experience, my in-depth understanding of child development, and my ability to see what the effect is of change over time, over a lifetime, I am able to give a realistic idea of where someone is going to end up in their skill set. Now, if I see a 4-week-old child, which I do, I see people as young as 4 weeks, and we see people as old as in their 70s, I will say, no, I can't do that, because we know from a neurological point of view, those children do not show tone quite in the same way as when they come up against gravity and become active. So, but if I see a 7-year-old who is still eating by just moving the mouth up and down rather than using rotation forward, backward, and up and down integrated, I don't call that munching. I call that is disordered. That is not a typical thing to do anymore when you're 7. So I call that a disorder rather than a developmental delay. Does that make sense? They're two different things. They're very different. One of them will lead to typical, the other one does not. So yeah, we don't diagnose, but we can give, on the basis of using the GMFCS, things like that, we can give a realistic understanding of what's going to happen in the near future.
Okay, so it's more comprehensive. You write down what has been observed.
So the therapy team here are often asked by doctors, what do you think about this child's neurological presentation? We describe it, and the point of doing that is that it gives us ideas about what to do next, rather than to put a label on it. The label is in itself not that useful. Giving an idea of what you could do next is. And parents, on their journey, that is more helpful to them. It's positive way of looking at it rather than a negative way of looking at it. Does that make sense? Do you understand?
Absolutely. Here in India also we have vegetable principles, and we want to change the system also. That's why I asked this question to you.
Of course. So the other, just one more thing. People who come here can self-refer. They do not need a referral from a doctor to come here. And the reason for that is that people who live with cerebral palsy or an allied condition, they know something's not right. And parents always get it right, always. So we see them. So we offer them a free welcome session, which is time that they can talk to a therapist here that we pay for, to discuss their concerns, to see if we could be of use to them. And if we're not, our duty is to signpost them to the people who can be of use to them. That is our role as well.
Nice. Nice approach. Okay. You have another, as we discussed, you are around 30 years of experience. Can you also tell us, using this Bobath approach, I'm very sure you are in this organization for 30 years, must have a lot of things to believe in. Kindly share us, what outcome have you seen in this patient in your 30 years? How do you see it?
Well, I have met some absolutely inspirational children in my time, and one of them is a young lady who I met at the age of 6 who had real problems with her speech. And it was a journey because she was a speaking person. She's level 4 GMFCS. She's a speaking person, but her intelligibility to familiar people is probably about 50%, to unfamiliar people, much less than that. So I started working with her at the age of 6, and she is now a doctor in astrophysics. She did a graduate degree, a master's degree, and then she did a PhD in astrophysics. And she lives independently with a group of carers, and she can communicate her needs now to whoever needs to talk to her. And that is on the basis of us starting. Another one is a little boy who came to us age 18 months, non-verbal, never developed speech. I started using symbols with him when he was 18 months old. And at the age of 3, he was using eye gaze technology to communicate effectively and answering open questions. And he is now in a mainstream secondary school, and he wants to go to space. That's his wish. Yesterday, I met a little girl with a very significant genetic syndrome. And by the end of the session, the goal was for her, by the end of the session, to understand that the switch would enable her to have a favorite activity again by pressing it once instead of just knocking it. And we achieved that at the end of the session. So we set goals in every single session, literally every session. Yeah.
Great.
So yeah, I've met amazing people in my life. I've met people like you from abroad who have a different experience and a different background and a different set. And I'm very privileged that through the training side of the Bobath Center, we have trained thousands of therapists across the world. I've been to South Africa, Mexico, Argentina, Poland. I've taught across the world. And without exception, when you start to talk to speech therapists about, would you not like to be able to actually do something about the reason why somebody's head is falling down all the time, that they come across and say, yes, I really would like to learn to do that. Yeah.
Right. So you have training programs also and courses in your institute, right? Would you like to tell about that as well?
Yeah, very briefly, we run a whole host of courses for people. We run courses for people who are therapy assistants, who are carers. We run courses for parents. We run courses especially for speech therapists. We run courses that are 8 weeks long, where you really learn how to use your hands to make a difference. Because don't forget, when we look at problems with communication, speech, saliva control, breathing, voice, communication, it comes from this brain that doesn't work quite like other brains do, and that results in atypical tone. To be able to do something about atypical tone means I can be effective in making something happen. So that is what you learn when you come on a course here. So we run an 8-week course, which is for anyone who's a therapist, for doctors as well, to get a really good in-depth understanding of typical development, atypical development associated with cerebral palsy in its widest presentation, because there are so many different presentations, and then how to actually make changes. And it's a very practical thing. So you go and work with children while you're here. We do that in our center in Watford, but we also do it literally across the world, anywhere where we're asked to come. We try and support. Yeah.
I know it's there is so much a plethora of information. It's something new for our population also. People can go back to your website and know more about it.
Definitely. I can see we only have 1 minute left, Peter.
Yes,
So
please, yes. Would you like to say something before we end up this meeting?
I really do, because I'm aware this is a wonderful time of celebrations for you and the people in your country. So I would say happy Durga Puja and happy Diwali to everybody. And thank you for listening to me. And if ever you want to get in touch with us, just write to us via email to contact@bobath.org.uk. And I hope Peter will put that information in the little blurb that comes out with this recording.
Sure.
Thank you for inviting me, Peter, for being absolutely wonderful.
We are so glad we had you here, and so nicely you have said Hindi to us. It's making our celebration, much more brighten us with your presence today.